Okay, perfect. Let's get started. So today's topic is about type 2 diabetes, and mainly we are discussing about two drugs because most of the time, if the patient has to decide, okay, which drug is better for me and what are the benefits and adverse effects, so we as a physician have to tell them that, oh, this drug is better than this because of this and this things. So that's why I picked this topic. And on top of that, a lot of my family friends are also having a history of diabetes. So this is something I've been always passionate about learning and getting to know more. So today's topic is Tirzepatide versus semaglutide once weekly in patients with type 2 diabetes. So mainly we will be covering two drugs and we'll find out which one is better over other and why. So if you look at this picture, this is telling you how the food is being consumed. And as soon as the food is being consumed, there is high amount of glucose. And because of that, the action of GLP-1 receptor and GIP takes in place. And it will mainly function on brain, on pancreas, on stomach, and then on fat tissue. The two drugs that we are discussing today is semaglutide, which is a GLP-1 analog, and Tirzepatide, which is a dual. That means it functions as both for GLP-1 and GIP agonist. If we look at the function of GLP-1 and GIP receptors in the brain, it usually suppresses hunger because of hyperglycemic state. For pancreas, it's going to stimulate insulin secretion. It's going to suppress glucagon. I know many of you know this, but just in case, if somebody wants to know what glucagon does, is glucagon is gone when you are insulin is when you are in a hyperglycemic state, and glucagon is released when you don't have much glucose in your body and you are hungry. And then for stomach, these receptors function as it slows down gastric emptying. And for fat tissues, it's gonna increase the glucose uptake. So a little bit of more background of what the GLP-1 receptor does in our body. It's the same thing. It decreases body weight, it decreases appetite, it delays gastric emptying. It's going to be decreasing glucagon secretion in the hyperglycemic state, which makes sense because we are already hyperglycemic. We don't need a lot of more glucose to our body. And then it increases insulin secretion in hyperglycemic state as well. So adding to it, first of all, we will be worried like, oh, where are these receptors are? We'll be wondering about it. So they are most abundant in adipose tissue. And what it will do is that they will enhance the lipid buffering capacity so that more adipose tissue can be made from the glucose that is present in our body. And in that way, it will be preventing the ectopic fat deposition. Um, why this study? So mainly we will be discussing about these two drugs, tirzepatide versus semaglutide, and we will be looking for the safety and efficacy and how it is important to know before we prescribe this drug to our patients. And in today's world, in the market, we have been having so many new interventions, and day by day, there are just a lot more options to pick from. So these studies are actually very important to narrow down our choices. As I said, tirzepatide is a dual. That means it works both with GLP-1 and GIP agonist. And the main hypothesis that has been tested in our study is that tirzepatide may have greater effect on glucose level and weight reduction as compared to semaglutide. So this is the main hypothesis that we are testing throughout this study. So three main questions that we will be looking for is that why tirzepatide drug is better over other? Was there any effect on the hemoglobin AIC1 between the two drugs? And then how many side effects are associated with these two drugs? So these are the main three questions that we will be answering throughout the study. So if we look at the the research itself, what they did was it was a 40-week research that they did, and it was an open label. So that means both researchers and participants were aware that which drugs have been prescribed to them and how are they going to take it. So they were all aware of what's going on in the study. It was not a blind study, and it was actively controlled, and it was a phase 3 trial. There were 128 sites across the US, UK, Argentina, Australia, Brazil, Canada, Israel, and Mexico. So it was to cover the maximum population, and it was to cover the various amount of phenotypes that are present in our population to see if this drug is applicable for every individual possible. So they started with 1879 patients, and they were randomly assigned the drugs. Some patients were assigned Tirzepatide drug, and some were assigned Semaglutide drug. And the maximum dose for Tirzepatide was 15 milligrams, and the maximum dose was for Semaglutide was 1 milligram. And then they started with like the lower dose, and they kept increasing until the maximum level, which was 15 for Tirzepatide and 1 milligram for Semaglutide. So with Tirzepatide, they initiated a drug dose of 2.5 milligrams once weekly, and the doses were increased by 2.5 milligram every 4 weeks until the assigned dose of maximum limit was reached. And then for semaglutide, as I said, they initiated at a dose of 0.25 milligrams once weekly, and the dose was then doubled every 4 weeks. And then they just kept it very strict throughout the research study that if the patient is suffering from any severe symptoms, then only they will give any other different anti-hyperglycemic medication. Otherwise, they will stick to the regimen that was assigned to the patient. What were the inclusion criteria to get people enrolled in this study was that the age has to be more or equal to 18 years. This was, again, because most of the patients we know that with type 2 diabetes usually come around these age. And then all the type 2 diabetes patients, they were controlled with metformin at a dose of at least 1500 milligrams per day. That was one of their requirements. Their HbA1c level has to be from 7 to 10.5. Your BMI has to be at least 25. So nobody under the weight could enroll in the study. And there has to be a stable weight, not to gain, not too much of losing of weight during the previous 3 months. So these were the five criteria that they were really looking for in the people who were trying to enroll in this study. The exclusion criteria were opposite to what was for the inclusion. Any patients with type 1 diabetes, since this study is mainly for type 2 diabetes, none of the patients with type 1 diabetes were enrolled. The GFR, it's very important because every time when a patient is diabetic, we have to monitor their pancreas, we have to actively monitor their kidneys as well. So they were looking for a specific GFR rate too, which was less than 45 ml per minute. If the patient has a history of pancreatitis, they do not include those patients. And the patient who had retinopathy is when you start seeing like cotton wool spots in the eyes and retina, which is an indication of the patient's diabetes is not controlled properly. So all of these patients who had an indication of diabetic retinopathy were also not included in the study. So usually the studies for this diabetes patient, all the studies that I have read about usually last long because they are looking for long-term consequences of this drug. So this trial was conducted from 2019 of July 30 to February 15, 2021. And all the patients were randomly assigned. And at the end, 1878 patients, 1,878 patients received at least one dose of either Tirzepatide or Semaglutide. For the baseline, after they had all the patients enrolled for the study, they did calculated a baseline because every time when you conduct a research study, we have to have a baseline to have the comparison of before and after. So before they started study, all the patient populations, their mean duration of diabetes was 8.6 years. Their mean HbA1c level was 8.28%, and the mean body weight was 93.7 kilograms. So this is what we have before the study, and now we're going to go ahead and do the study, give the drugs to our patient, and find out what's going to happen after. And as our hypothesis was saying that it has to show reduction, so now we're going to look for if there was actually increased or decreased after taking the drug. Sorry for this picture. Every time when I was trying to extract this picture from this study, it was kind of coming blurred. But this is the same thing that I was saying, the baseline levels for tirzepatide and semaglutide. It was around this range, which was 8.32%. So these are the outcomes. As we were saying that if you take tirzepatide drug, which is a dual GLP-1 and GIP receptor drug, we were expecting, according to hypothesis, reduction in the body weight and reduction in the hyperglycemic state. And that's what happened too. After the study, after the patients were given the drug and the measurements were taken, we find out that if you are taking tirzepatide drugs, so these brown columns are for semaglutide, and all the blue colors are for tirzepatide. So if you zoom in, you will be able to find out that semaglutide had a reduction of 1.86, whereas for tirzepatide, the reduction was always more than 2, like 2, 2.5, things like that. So it actually shows that the effect of tirzepatide drug is more on HbA1c level on diabetic patients as compared to semaglutide drug. This is a picture for body weight and lipid profile. Again, you can see these brown color columns are for semaglutide, which is around 5.7 reduction. And for tirzepatide drug, it was 7, 9, 11, basically more than what the semaglutide drug for the reduction of body weight. So in short, there was a reduction in the HbA1c level with the tirzepatide drug, and it was usually around the range of 2.24% and 2.30%, depending on which dose was administered to the patient. If we talk about the HbA1c level, a total of 82 to 86% of patients who received tirzepatide drug have seen reduction less than 7%. And then reduction in the body weight with tirzepatide drug was also dose dependent. But if you compare two drugs, tirzepatide was winning with more reduction in body weight and then more reduction in HbA1c level in diabetic patients. And then now we already know that tirzepatide drug is way more efficient and it is way more helpful in patients in reducing their body weight and reducing their diabetes level. Then we got to worry about what the side effects are, right? So for the side effects, if we compare the two drugs, the side effects are basically the same, which is nausea, vomiting, diarrhea, abdominal pain, decreased appetite, fatigue. So there's not a significant amount of side effect which can lead us to a conclusion that, oh, tirzepatide has way more side effects as compared to semaglutide, because both the drugs have same side effects. So nothing to worry about in terms of side effect because both drugs cause the same thing in the body. Now, talking about the strength of the study, it was a really good trial because they included a lot more people from all different continents. So really large sample size with large number of patients completing this study. Another good strength was active competitor. Usually, if we look at other studies, one is like the base level, and then we compare with something which is after the study. Whereas for this one, there were two active drugs that were like parallelly compared throughout the study. So that is also one of the strength for this study. And then again, all the results that were presented in this study were similar with what the previous studies were saying. I looked up the SUSTAIN study and I also looked up the step 2 trial study, and basically the results were similar to what we have found in this study as well. Some of the limitations could be the human error measurement. We always have to worry about that, and difference in the devices that we use throughout the trial. Because at the end of the study, they were mentioning that there were certain devices that they kind of switched every month, and there were like people who are on different shifts who are measuring this diabetic patients. So there could be a chance of human error. And another limitation could be the number of participants that were African American were low. So the number of patients, particularly to African American ethnicity, were low. So we don't know if this drug has actually been working with them or not. And higher dose of semaglutide were not available. In the beginning, I said that the maximum dose for semaglutide was 1 milligram, whereas the maximum dose for tirzepatide was 15 milligrams. Because at that particular time, the maximum dose allowed for that drug was only semaglutide for the test trial. So it could be also one of the limitation. My final thoughts on this is, according to me, I truly believe that tirzepatide is a good option for patients who are willing to take type 2 diabetes medication once weekly. Yes, side effects are present, but I mentioned that both the drugs have same side effect, and they are not very dangerous enough to rule out one over another. And the patients, one another thought is that if you look up for a patient's preference of how they would like the drug, patients who would prefer oral route of administration would still prefer semaglutide because it offers both cutaneous and oral route, whereas tirzepatide is only administered subcutaneously. So I would still prefer tirzepatide drug over semaglutide, but if the patient walks in and tells me that I want a drug which could be administered orally, then at that time I would prefer semaglutide drug over tirzepatide. But I still believe that tirzepatide is a better drug as compared to semaglutide if I have to pick for my patients. And that's it. Any questions for me?